Okay, so good evening everybody and welcome back to Fertility Week. This week we've hosted 5 webinars on the 5 usual suspects of infertility. So on Monday we had endometriosis, Tuesday male factor, Wednesday was polycystic ovary syndrome, Thursday or last night was recurrent pregnancy loss, and tonight's is going to be our last of the 5 and it's going to be on unexplained infertility. So Fertility New Zealand is a registered charity that's been operating for about 20 years. We're here to support New Zealanders on their fertility journeys, and we do this by providing information in the form of leaflets, videos. We've got an 0800 telephone number and an email address. And we also provide support through a variety of support groups spread across New Zealand. And we also provide advocacy. Tonight's speaker is Dr. Guy Gudex, who is the Medical Director of Repromed in Auckland. The format's going to be the same as last night. We'll do the presentation and then the questions at the end. Please type the questions into the chat box. So no further ado, I'll pass this over to Guy, and thank you very much.
Oh, thank you very much for the introduction and thanks for the opportunity to speak on the topic of unexplained infertility. As you're probably aware, unexplained infertility can be quite a frustrating diagnosis, and it can actually be much more helpful for couples to know if there's a definite sperm problem or a definite tube problem. Unexplained infertility essentially means that the testing that we've done hasn't turned up any underlying cause. That doesn't necessarily mean there isn't an underlying cause, and as I'll touch on soon, probably there can be some quite subtle sperm problems that our testing isn't sophisticated enough to detect. How is unexplained infertility diagnosed? Primarily, it's diagnosed by seeing if the patient has patent tubes, so you need to know whether the tubes are blocked or not. We need to rule out whether someone's got endometriosis, and clearly also we need to know whether the patient's ovulating or not. It's important that couples are having regular intercourse for at least a year to make the diagnosis, but as again I'll explain soon, it's important that if age is a factor, that it may not be sensible to wait up to a year before you start having investigations done. It's really only after all the tests are back that we're able to say whether this is in fact unexplained infertility. And as I'll touch on at the end, the diagnosis of unexplained infertility is also important because of the impact that that can have on your access to government funding. Unfortunately, at the moment, the way the current rules work, if you do have unexplained infertility and there's absolutely no other factor that you can get points for, you need to have been trying for 5 years before you can get the threshold for getting government-funded treatment. We would generally recommend that you start investigations after 6 to 9 months if age is a factor. And normally the advice would be after 12 months. The testing that needs to be done is obviously going to include ovulation, and that's normally with a progesterone blood test in the second half of the cycle. Ovarian reserve testing, and I'm going to talk in a minute about AMH, which is a very useful blood test to benchmark where someone's at in terms of their egg numbers. And obviously tubal patency check's important, and that can be done either with a laparoscopy, which is a camera in the tummy button under a general anaesthetic, or a hysterosalpingogram, which is an X-ray that can be done as an outpatient. The advantage, obviously, of a laparoscopy is that it gives you the opportunity to diagnose endometriosis, whereas a hysterosalpingogram will simply tell you whether your tubes are patent or not. And it is important to have endometriosis diagnosed for a couple of reasons. One is that obviously it will help you get more points and help you get access sooner into the publicly funded system. But also if you do have endometriosis, it's not unexplained infertility. And if endometriosis is treated, it can certainly improve your chances of becoming pregnant spontaneously. I just want to make a comment about age, because although we talk about unexplained infertility, a woman's age particularly can have quite an impact on her chances of getting pregnant each month. And in New Zealand over the last 20 years, we've seen a trend where women are putting off getting pregnant until they're a little bit older. That trend probably has slowed down, and on average now it's about age 30 that people will have their first baby in Auckland. But the importance of that is that there's therefore, if that's the average, there's a greater number of women aged 35 to 39 who are having children for the first time. And we know that as you get older into your 30s, there's definitely an effect on fertility and on your fecundity, which is your monthly chance of getting pregnant. If you go back into the 1970s, people got married in their early 20s and often started having children at 22 or 23. This slide is really just demonstrating that as a woman gets older into her mid and then late 30s, the chances of getting pregnant does decline. Now, most people in the end, if they try for long enough, will in fact fall pregnant. And there's quite a famous research study done on a Hutterite community in the north of the United States of America. And that's a community that doesn't use contraception, and they start trying to have a family from a young age. And they found that most people, but certainly not all, did fall pregnant eventually. The message from that, again, is that the length of time that you give yourself in which to fall pregnant is really important. And that's the dilemma, in a way, with starting to try and get pregnant when you're older, is that you're giving yourself less time to get pregnant. Just a comment about the sperm test. As a preliminary test, we'll get that done at a community laboratory. And then if we have any concerns about the parameters, then you'll get a sperm test done in one of the fertility clinics. And what we're interested in is the count, the morphology, which is the shape, and the motility. All of them are important, and there's certainly a concern that over the last 70 years, sperm has declined in quality. The count's progressively been reduced from 30 to 20 to now 15 million per mil is the lower limit of normal, with the WHO guidelines. We don't want to put too much reliance on one single test, and if there is an abnormality, we'll often advise that it's repeated 8 to 12 weeks later. But clearly, semen analysis is very important. And I just want to say a word about a further test that we can do on sperm if the diagnosis appears to be unexplained, and that is to do what's called a tunnel test. We can do a measurement of the genetic health of sperm. It's as a percentage, it's not each individual sperm. And it's apparent that particularly as a man gets older, into his 40s and 50s, or if there are lifestyle factors present, such as being overweight or smoking, that can interfere with the DNA integrity of the sperm and affect chances of getting pregnant. Tunnel test is simply staining the sperm with a fluorescent dye and then looking at under a microscope and counting the number of fragmented or abnormal sperm compared to normal. And we would think that anything over about 20% is clinically significant. There's a move towards doing DNA testing on sperm before recommending tests such as intrauterine insemination, because there's some evidence that if the DNA integrity is reduced, the intrauterine insemination, which I'll talk about soon as a treatment, might be less successful. AMH is a blood test that we can do on a woman. It can be done at any stage in the menstrual cycle, and it's made a massive difference to our ability to benchmark her ovarian reserve. And really, it turns out that some people that we label as unexplained infertility, in fact, probably do have quite a significant ovarian reserve issue, and that might actually be the main problem. AMH is a hormone that's produced by follicles which have eggs in them. So if you have less eggs, you will have a lower AMH. It is affected by the oral contraceptive pill in some people. And so if we find a low result and someone's on the pill, then we'll get them to stop the pill and repeat it. But we've found that AMH is very helpful for picking up people who otherwise appear to be completely normal, but in fact have a low ovarian reserve. And the advantage of knowing that is that we can give them some advice about what sort of treatment should they consider, how long is it reasonable to keep waiting. It's been around for about 4 years in regular clinical use. It unfortunately costs about $60 because it's not free. It's not yet on the public schedule. And we use it now on everyone who's having treatment to help predict also what dose of drugs to give them. And it's very useful for predicting your response in IVF and predicting how many eggs you're likely to get or in what range of eggs you're likely to get. And this graph just shows the range of normal. Down in red is the low ovarian reserve. When someone does the test, we can then plot it on the graph and give them some idea of where they're at. It's important also to know that the rate it's declining is important, and so we'll often repeat an AMH a year later and try and get an indication of what's happening with that person's ovarian reserve. In terms of treatments for unexplained infertility, clearly waiting once all of the investigations have been done is an option. And the decision to wait will be based on that individual couple's choice, how they're feeling about the fact that they haven't got pregnant to date, how old they are, so that's going to play a major factor in how much longer they've got left. And also clearly there'll be important lifestyle changes to make if that seems appropriate. The commonest treatments probably for intrauterine insemination are intrauterine insemination with or without clomiphene, or IVF, but I've mentioned also on that slide Lopidol, which is a flushing of poppy seed oil through the tubes. Quite a big study at National Women's a few years ago showed that there was a doubling of the pregnancy rate in the 6 months afterwards when couples had Lopidol flushing. And although it wasn't completely certain whether that's having an effect on the lining or whether that's an effect on the fallopian tube, that seems to be real. I'd point out also, though, that any sort of tubal flushing, whether it's at a laparoscopy or with a normal hysterosalpingogram, has shown to have an increased chance of getting pregnant in the following few months. Intrauterine insemination is useful. We really want to do it when the sperm's completely normal, and there's a lot of debate as to whether you need to add in extra stimulation with clomiphene or not, because adding in clomiphene will increase the risk of twins and multiple pregnancy. And certainly in the United Kingdom, it's most common to do intrauterine insemination without clomiphene. In New Zealand, it would probably be commonplace to do it with a bit of clomiphene. The thinking being that if there's 2 or 3 follicles there, 2 or 3 eggs there, then the intrauterine insemination has more chance of success. A daily blood test is done about from the 7th or 8th day, and that blood test is picking exactly when ovulation is going to occur, when the brain surge is going to occur, and insemination is done usually the next day. IVF is probably the treatment that gets the most publicity and can be very useful. Can be very useful as an adjunct to treating unexplained infertility. Some of the things that I wanted to mention about IVF are the fact that there's a lot of things that have changed in the last few years to make it more patient-friendly, make it simpler, and also make it safer. As I mentioned, access to government-funded IVF is quite restricted. A woman has to be under 40 years of age, needs to have a BMI of under 32 and be a non-smoker. And as I've said, unless you have some other factor, you're going to need to have been trying for 5 years before you get enough points if you've got unexplained. And in a lot of regions now, there's unfortunately at least a 12-month wait for publicly funded treatment, even when you have enough points. In terms of what's got simpler about IVF in the last few years, one of the things is the introduction of a so-called short IVF cycle. And this compares to the older long cycle by the fact that the injections to stimulate the egg production are started the day after a period commences. And that's all shortened down to probably about 10 to 12 days of injections before the egg retrieval is done. An antagonist drug is added in on about the 7th or 8th day, and that's going to hugely shorten the whole length of the cycle. The antagonist drug's purpose is to block ovulation so that we have complete control. And then when we're ready, based on the blood test levels and the scan, a triggering injection can be given and the egg pickup can be performed. Antagonist cycles have reduced quite significantly the risk of something called hyperstimulation, which is where too many eggs are made in response to the drugs. But AMH, which we can now do before an IVF cycle to predict how someone's going to respond, is also made a huge difference to allowing us to predict what the likely response is going to be. And that's really important when someone has a degree of polycystic ovary, for instance. We can predict that usually on an AMH level and titrate the dose of drugs accordingly. This slide here is really just showing you what an ovary looks like once someone's been stimulated for a few days with the IVF drugs. And so this is an ovary. You can see the black follicles. It looks a little bit like a bunch of grapes. And those follicles are getting quite mature. And so this person's probably not too far away from having an egg harvest. The other big change that's happened in IVF in the last few years is the significant reduction in twin rate. So in New Zealand, we mostly put one single embryo back, probably 90–95% of the time now. And we've managed to get the twin rate to down to 5% or less. And that compares really well to countries like the United Kingdom, which is still sitting up at 20%, and the USA, which are probably sitting up at 25%. So New Zealand, in some respects, really leads the world with that. And that's really important because twin pregnancies do have a risk of premature birth and increased obstetric complications. I also wanted to say a word about microinjection or ICSI, because one of the dilemmas we always face in IVF, particularly when a couple have had unexplained infertility for some time, 4 or 5 years, we're always concerned a little bit that there may actually be an underlying sperm issue that we haven't been clever enough to diagnose. And so we will err sometimes on the side of doing microinjection when a couple are doing IVF, if it's long-term unexplained infertility. And microinjection, very simply, is something that happens in the laboratory after the eggs have been harvested. And this first slide shows the round egg being held against the glass suction pipette on the left, and there's a needle coming in from the right, which has had a sperm sucked tail first into it. In this next slide, you can just see the needle going in through the outside of the egg into the nucleus, and the sperm is deposited inside, and then the needle is removed. ICSI's been around since the mid-90s. We do it quite commonly, probably about 50% of cycles we use ICSI. And we use it, as I said, primarily where there's a recognised sperm problem or long-term unexplained, and we're concerned about the chance that there may be very poor or no fertilisation. That's the last of my slides. I just wanted to finish off by saying that unexplained infertility can be a very frustrating diagnosis for couples to have, but there are treatment options available, and so long as age isn't too much of an issue and ovarian reserve isn't too much of an issue, couples can usually be helped. Thank you very much.